Okay. So let's discuss some types of anemias, how the anemia can be treated and how they show the oral manifestation also, right? So anemia, we already discussed, defined it. Either the RBC count is less than 4 million per microliter or the hemoglobin less than 12 gram per deciliter or both. So anything is there, any condition out of these three, then it is called as anemia. So there are different levels of classification of this. One is the etiological classification. That means based on the pathophysiology, based on its causes, right? Whenever you see etiology, that means the cause. Based on its cause, we classify the anemia. First is the hemorrhagic. That means you're losing the blood, so your RBC count will be less, right? And the RBC must be containing some hemoglobin also. So both, in this condition, the both will occur, right? The hemoglobin will be less as well as the RBC count will be less. Then the dietary deficiency. For the production of RBC, a simple cell which is having the significant amount of function, that is transport of oxygen, it is going to require many things for the production also, right? So what it is going to require? It is going to require proteins, ions and various vitamins, right? If you are not having those in your diet, obviously your body will be deficient into those elements, right? And what will happen? The RBC production or the hemoglobin production will not be normal, right? That range will be deficient too, and that's why you are going to get anemia. Then the abnormal hematopoiesis or hemopoiesis. Suppose your diet is normal, right, and you're not having any blood loss condition also, then what happen is, in the bone marrow some abnormality is there, even all the things are there, it is not able to convert that into the RBC, right? It is not able to form, right? So that is known as abnormal hemopoiesis, right? Such as aplastic anemia. Aplastic means absence of plasticity, that is modulation or formation of the cells, right? In the hemolytic anemia, suppose everything is normal, you're not having any blood loss, you're not having any deficiency in the diet, you're not having any hemopoiesis kind of condition, but what happens? The formation of the RBC is normal, but the destruction is very early. So what happens? They should be balanced. The production and the destruction should be balanced, right? But if the destruction increases, the relativity of that production will not be compensated that much. If the condition is chronic, you cannot produce that much of amount of RBC every day, right? So you can get anemia. So excessive destruction of the RBC, that is known as hemolytic. The lysis or lytic means to break down the RBC, right? Okay, so let's see another classification. They just subdivided it, right? So due to blood loss, that is hemorrhagic, acute or chronic. It can be acute or chronic. Inadequate production, that is either due to diet or abnormal hemopoiesis. Iron deficiency anemia, megaloblastic anemia, pernicious and aplastic anemia, right? Due to excessive red cell destruction, if the destruction is more, what you're going to get? Either the hemolytic one or sickle cell. You just have to remember that what is the pathophysiology, and easily you can get the classification that under what condition they are coming, right? Now, depending on their size also, we have different classification, right? The first one was due to the causes, right? Now we are moving on to the sizes. There are different sizes and different colors, right? So depending on whether the size is smaller or larger, we have different anemias, right? So what they known as, the terminology for that is microcytosis. Micro means smaller ones, right? Cyto means cell. So microcytosis means smaller size of cells. So average size of red blood cell is reduced in this. In which condition or anemia this occur? In iron deficiency anemia, it can be seen. Then hypochromia. Hypo means less, right? And chromia means color. Just remember, chromia means color. So if the color is not that red, right? As you can see in the normal person, so the anemic person will looks as if they are very, very pale, and that is known as hypochromia. And again, this can be seen in the iron deficiency anemia. What is the cause of this? Less amount of hemoglobin, less amount of oxygen is there, less red color will be there, right? Easy. Then macrocytosis, opposite that of the micro, right? Micro means smaller, macro means larger, right? So macro means the cell size got increased than the normal, so greater than the normal RBCs, that is macrocytosis. That can be seen in the megaloblastic anemia. We know that mega means big, right? So megaloblastic anemia, that means the RBC got big in size, right? And isocytosis. So iso, we heard isomers, isotonic, right? So what do you mean by iso? Iso means same, right? So size of the RBCs in the normal person is almost same, but if they are not same, and means not same, right? So anisocytosis means inequality in the size of the cells. Some are larger, some are smaller, right? Some are medium size. So if the size is not matching, there is much of a variation in the size, then it is known as anisocytosis, which is seen in the megaloblastic anemia. So on the basis of normocytic, normochromic, or hypochromic, we do have this classification. They ask in the exam the Wintrobe's classification, right? So they can give you any deficiency anemia or any anemia, and they ask you to identify which type of anemia it is. So you must be knowing. So in that side, this side we are having normocytic, macrocytic, and microcytic on the size. This is based on the size. And normochromic and hypochromic. Definitely you are not going to get hyperchromic. Why? Because in the anemia, the oxygen carrying capacity is less, right? So we are going to only have two columns over here. So this is based on the color, right? So normocytic, normochromic anemias are these ones. That is acute hemorrhage, hemolytic, and aplastic anemia. Hypochromic normocytics are seen in the chronic hemorrhages, right? In the macrocytic, we know megaloblastic, that means the size is increased, right? But the color will be normal. In the liver disease, the cells will be big, but the color is also decreased. So that is hypochromic macrocytic. Microcytic normochromic is seen in the chronic infection, and this is very important. The last column is very, very important. That is iron deficiency anemia and thalassemia. Both the size is also reduced and the color is also less, right? So hypochromic macrocytic type of anemia is seen in the iron deficiency and thalassemia. These are very, very important. If you want to remember only one column, just remember that last column, which is very, very important. Okay, so causes of anemia we discussed, it can be due to any cause, right? Either bone marrow is not normal working, any genetic factors are there, hemorrhagic, that means bleeding is there, menstrual bleeding if it increases, iron deficiency if diet is not proper, in which the iron is not there, right? The cancer causing anemia, if the cancer is there, which is taking the toll on the bone marrow, so the bone marrow is not able to produce much of the RBCs, or impaired metabolism, or any exposure to the free radicals or X-ray or something like that. So radiological items, so that can cause the anemia. Megaloblastic anemia, we know macrocytosis is seen and cytosis is seen. Then it is having further two types of anemia, that is vitamin B12 and folic acid deficiency anemia. So let's discuss one by one what are the types of anemia. The first is pernicious anemia. This is having lots of name, right? You must be having nickname of yours also. In the schools, you must be called by some other name. Your close friends call you by some other name, right? Your mom, dad call you by other names. So like that, this anemia is also called by various names, right? Let's see that. Addison's anemia, destructive anemia, injurious anemia, or pernicious anemia. these are nothing but the same anemia. Whatever the examiners ask in the exam, these anemias are the same, right? So why this happens? So remember, there is the atrophy of gastric mucosa. You have a stomach, right? In the stomach, what happens is there are parietal cells which secrete the intrinsic factor, which is required to carry down the B12 towards the terminal ileum so that it can get absorbed into the blood, right? Otherwise, all the enzymes inside the gastric mucosa and all the pancreatic enzyme into the duodenum, they will destroy the B12, right? So, to B12 to carry, you require this intrinsic factor. If by any cause this intrinsic factor is not there, suppose in this anemia per se, what happens? There are antibodies which are formed against this parietal cell and they destroy this parietal cell, and that's why the intrinsic factor cannot be produced. If the intrinsic factor is not produced, what will happen? The B12 cannot be absorbed because it is not having any protector, which was the intrinsic factor, right? And it get destroyed before it coming to the terminal ileum. So lack of intrinsic factor that causes failure in absorption of vitamin B12, right? And the major cause is antibodies to the intrinsic factor or the parietal cells, right? And that's how we can diagnose it. What are the blood changes that you're going to see? The RBC numbers will be decreased, right? Anemia, there is anemia, so numbers will be decreased. And what type of anemia you're going to see? Macrocytic normochromic, right? Macrocytic cell size will be increased. They cannot do the proper shape, right? And it is normochromic. That means the color will be normal, right? Just the size will increase. The hemoglobin will be reduced. Again, the anemia is there, right? And the reticulocyte will be increased. Why the reticulocyte is increased? What is this reticulocyte? This reticulocyte is a precursor of the RBC, right? Why this reticulocyte is increased is that the oxygen, the RBCs are reduced, right? And they are not be able to carry much of oxygen towards the tissue, right? So it is again the stimulating erythropoietin stimulating the bone marrow. So bone marrow, what it is doing? It is trying to produce the RBC more and more. But the stimulation is such high, what is happening? The immature cells, usually what the bone marrow is doing is they mature the RBC first and then send it to the blood, right? But the requirement is so high, what the red bone marrow is doing, it is sending the immature cells also, right? As done by the Hitler, right? What we do in the army, first we give the training to them how to fight with the enemy, right? But what Hitler did, he took all the men, right, to increase his army number, right? The similar thing is happening. The need is so high, the immature cells are sent into the blood, and that's why the reticulocyte, the precursor of the RBC, which is immature, that number is increased. Then you can see the hemolytic jaundice. Now what happened? The number is increased, right? But they are not the normal RBCs, right? The megakaryocytes are taken as if they are the abnormal RBCs, and spleen will break them down, and that's why you're going to get hemolytic. That means broken down RBCs, and you're going to get the jaundice. Why? Because the hemoglobin that is released from the RBC, that is going to create much more bilirubin, and that's why you're going to get jaundice, right? The major symptom that the patient is having, if the clinical case is given and any CNS symptom is given and they ask which anemia is there, blindly go for the pernicious anemia. Why? Because in the pernicious anemia, you have demyelination, right? So patient will feel like tingling, numbness, the sensations in the limb, and there can be motor and psychological disturbances, as well as graying of the hairs can be seen in the pernicious anemia, right? What you can do in the treatment, you can just give the B12, right? Let's move on to the folic acid deficiency anemia. Folic acid deficiency, the name itself suggesting that there is a deficiency of this folic acid, right? And you can, this is very, very common. Why? Because most of our food is not having much of the folic acid. So if you see the human population or the female population in the India, the majority of anemic female, they are going to have this folic acid deficiency or iron deficiency anemia. What type of anemia you are going to see? The important thing is megaloblastic anemia will be seen over here without any neuropathy. If the CNS symptom is occurring, that means it is pernicious anemia. If no symptom is occurring, right, and still it is megaloblastic anemia, the only difference in these two types of megaloblastic, both are the types of megaloblastic anemia, pernicious also and folic acid also, right? What's the difference? In pernicious, you are going to get CNS symptoms. In the folic acid anemia, you are not going to get any CNS symptoms. So without any neuropathy. So causes are less dietary intake. It can be dietary intake is less, or dietary intake is normal but absorption is poor, right? Or the demand is increased, which is physiologically happens in the pregnancy, even in the infants, right? Or the patient is taking any anti-cancerous drug which are destroying the folate, right? So this can be the types of anemia. So these are the type of megaloblastic anemia. Let's move on to the next type, that is iron deficiency anemia. As I told you, it is most common anemia in the, specifically in the Indian females, right? So definition, what is that? Iron deficiency. That means the name itself suggesting that there is a deficiency of iron, and that is leading to the anemia. So if there is anemia which responds to adequate doses of iron, means any anemia, right, after which if you take the blood samples and let checking the all the patients that whether it is iron deficiency or not, it will take a lot of time, right, and lot of resources. So what you do is you give the iron. If it responds, that means if the patient recovers from that anemia and symptoms are getting less and less every day, that is known as iron deficiency anemia. So this is the proper definition given in almost all authentic books. So any anemia which responds to the iron doses, that means the deficiency was there, you filled up the deficiency via giving the tablets or intravenous iron, right, which patient responded to that via recovering from that anemia. So what can be the causes of this anemia? Iron intake is less, deficiency. Then like milk fed infants, if the infants are fed more than 1 year of the mother's milk, it is no more having iron, right? So they can develop iron deficiency anemia. Then the iron loss, if suppose there is any hemorrhage via the hemoglobin, you are going to get you are losing the hemoglobin as well as the iron into that, right? So there can be deficiency if the demand is increased, right? So what will happen in the pregnancy, in the infancy, in the menstruation, in the females, what happens? There are high demands of the iron, and if you are not properly supplying that much of the iron to the body, definitely the patient or the females usually lands up into the anemia. And now you must be getting why the Indian females are having more and more iron deficiency anemia, especially in the rural areas. Why? Number of pregnancies are high, and even if they are having high menstruation, because of some rituals or some different things, they do not go to the doctors and talk about all those things. So in the rural areas, females are suffering from iron deficiency anemia, right? Then defective utilization. If you are giving a proper iron to a subject, but it is not able to, the blood is not able to use that, right? Suppose in your account you have a lot of money, right? You have 2-3 lakhs or something like that, but you want 20,000, but your card is blocked, the ATM is blocked, your app is not working. What you're going to do? You're not able to use that. So again, the similar thing happens in the iron deficiency also. If everything is normal, but if the utilization is not there, then the patient or subject is land up into iron deficiency anemia. What are the features of this anemia? This is microcytic hypochromic. I already told you the last column is very important in the Wintrob's classification, right? The counts are normal. right? There's a deficiency in iron, but not in other factors. So RBC counts are usually normal. If you take the sample of the blood and you check for the serum iron, it must be decreased. Obviously, it is iron deficiency, so serum iron will be decreased, but the total iron binding capacity will increase. Why? Because this is a compensatory mechanism. So what you will do, you'll work harder to get cash, right? Because your card is blocked, your app is not working, and you need money. So what you do, you work harder, right? The similar thing will the RBCs will do. What they do, the binding, the attraction towards the iron will be increased. The receptor will be increased. So whatever amount of iron they are getting, they should absorb it to cure the situation, right? Then if you look at the nail, they will be dry, soft and spoon shaped. So if you see the nails should be like flat, almost flat, but if you see the spoon shaped, and that's why we do the diamond test. What is the diamond test? It is very easy. We ask the patient whenever you are coming, the patient is coming to the OPD, we are asking to do like this, right? And you can see the gaps between the two thumbs. If this gap shaped like a diamond, it is not there. Why? Because if this will get spoon shaped, the gap is not be seen, and that's why, and that is known as diamond test. The spoon shape will be definitely, this test is definitely indicating the anemia. And longitudinal striation. In the nails, you are going to have longitudinal striation, that is indicating towards the iron deficiency, anemia. And tongue, it is angry red. Why? Because it is not getting sufficient iron, and that's why it is looking like a very, very angry red color, right? Repeated chest infection. Why? Because the iron is not only important for the RBC, but also important for the WBC, right? And if you compare the RBC and WBC production, if you're using much of energy to produce more and more RBC, so that, why? Because in the lack of the iron, the RBCs are not working properly. So you require more and more people. Suppose 2 people know their work, right? And they can do efficiently, right? But if you hire 4 people who does not need know proper work, then also your work will not be efficient. You require more and more staff to get that thing done, right? The similar thing is happening over here. So production of RBC is also increased, right? And that is decreasing the capacity of WBC production. So chest infection will be there, dyspnea and palpitation will be there. The irritability, because lots of functions are hampering, the RBCs are not normal, and oxygen delivery is not normal to the tissues. So irritability, loss of concentration, headache and generalized body ache. And in the reproductive system, the male and female are going to see the impotence if it is chronic for the longer duration, right? So these are the features which are very common and can be seen in the iron deficiency anemia, right? Then let's move on to the next one, that is aplastic anemia. So this disease of stem cell producing hypoplasia of bone marrow elements, not only the RBC but also the WBC and platelets. All the cells are hypoplasic. What do you mean by that? Plasia means production. So very, very less production. Hypo means less, plasia means production. If all cells production is reduced beyond the normal range, that will give the hypoplasic state, and that will lead to aplastic anemia. Why? Because in those cells RBCs are also there, and we know if the RBC numbers are less, then also we call it as anemia less than 5 million, right? Then failure to production of all bone marrow cells, as we seen. So what will happen? Not only RBCs but also WBC and platelets will be less. So we will get pancytopenia. Penia, when we use word penia, that means less. Penia means less. Philia means more, right? So let's do the terminology. Philia means more and penia means less. We know cyto means cells and pan means whole. All the cells. Pan means all or whole cells, right? So everything is reduced inside the bone marrow, and that's why we call it as pancytopenia, right? The suppression of the bone marrow. The bone marrow is suppressed, so it is not able to produce much of a cells. What can be the causes? Causes can be autoimmune diseases. Our own body tissues are attacking on the bone marrow. That's why it is not able to produce these cells. Then cytotoxic drug specifically used for the cancer chemotherapeutic, means cancer therapy, used in the cancer therapy. Then the chloramphenicol or sulfonamides, some drugs, right? Benzene, toluene, and any kind of radiation via X-ray or CT exposure, right? So they can cause aplastic anemia. Next important anemia is sickle cell anemia. We talk a lot about sickle cell anemia. What is it? HbS is produced over there, right? And when it get deoxygenated, it goes into sickle shape because of the crystallization. What are the clinical features that are important? It can produce the hemolytic jaundice, growth retardation, skeletal abnormalities, and bone pain. Most of the patient will come with the bone pain. So in hematology, if the anemia is shown and bone pain is given, just look for the sickle cell symptoms, right? Why it is important and why I again and again stressing on that? Because it is going to show you the oral manifestation also, and that is important for us, right? There can be delayed eruption of the tooth, right? Then hypoplasia of the teeth, again less production enamel, and radiolucencies in the jaw, right? And osteomyelitis. So all these oral manifestation can be seen in this sickle cell anemia, and that's why this is a favorite topic of examiners, right? And you must be remembering all this while going to the exam. These whatever 4 things we talked about, this is specific for the sickle cell, right? This is not seen in all the anemias, right? So what are the other manifestation which can be seen in other types of anemia, general sets of oral manifestation which can be seen in any type of anemia? Generalized stomatitis, right? Then mucosal pallor, obviously it can be seen. Then the atrophy of filiform papillae of tongue. Then other thing is glossitis, disturbed taste sensation, angular cheilitis, then gingivitis, RAS, susceptibility to infection, candidial infection, and important and favorite topic of the examiners, that is Plummer-Wilson syndrome. Now what is this Plummer-Wilson syndrome? Let's have a look. In Plummer-Wilson syndrome, you are going to see a typical 3 sets of the symptom. If you add those 3, this is known as Plummer-Wilson syndrome. Syndrome is nothing but symptoms, a group of symptoms which can be seen only and only in one condition, that is known as syndrome. So it is a group of symptoms. What are the group of symptoms that we are going to see in the Plummer-Wilson? One is iron deficiency anemia, second is glossitis and stomatitis, and angular cheilitis, right? So all these 3 are combined to form all these 3 symptoms leads to the Plummer-Wilson syndrome. In addition, these 3 are means. If these 3 are present, definitely this is the Plummer-Wilson syndrome. If it can be shown with other symptoms, what are those? Pharyngoesophageal ulcer, dysphagia, that is difficulty in swallowing, right? And cracking and splitting of the nails. The nails can be slit itself without any trauma, right? Or in the slightest trauma, normally, which do not cause a splitting of the nails. That can be seen in the Plummer-Wilson syndrome, right? In the iron deficiency, it's just a picture. They can give you a picture and ask you to diagnose. So angry red tongue, right? So depapillated with angular cheilitis due to candida infection is shown as over here, and the angry red tongue is shown over here. So these 2 are the abnormal tongues, and you can see over here the bilateral angular, that means on the angle of mouth, right? You are going to have cheilitis and stomatitis. So these are the pictures which are usually we get in the iron deficiency anemia.